Hi everyone, my name is Michelle, and today we will be looking at an update on cardiovascular research. Today we will be talking about LDL, or low density lipoprotein, HDL, high density lipoprotein, and drugs that can be used to alleviate cardiovascular risk and cardiovascular disease. It is commonly said that HDL is the good cholesterol and LDL is the bad cholesterol. Now, why is that? LDL oxidized lipids are associated with the inflammatory state in atherosclerotic cardiovascular disease, and this association is cyclical. LDL oxidized lipids are produced, which creates an inflammatory state and further oxidizes more lipids. In this manner, we want to keep our LDL levels low. These LDL oxidized lipids may adhere to the inner surface of vessels, which is called the endothelium or the luminal surface, and this can create plaques that may build up and can cause clotting. And eventually, these plaques may rupture and the pieces may travel elsewhere to cause blockages in flow. Now, statins are a class of drugs which can be used to alleviate cardiovascular disease, and they work by blocking a rate-limiting step in the endogenous synthesis of cholesterol. So they block the HMG-CoA reductase enzyme, and this overall will reduce LDL cholesterol levels, which helps in keeping these LDL levels low. Investigations have been going on to look at proprotein convertase subtilisin kexin type 9, also termed PCSK9, which is a secreted inhibitor of the LDL receptor and an important regulator of LDL metabolism. And elevated PCSK9 levels have been associated with cardiovascular risk. Let's look at how PCSK9 functions at the cellular level. The PCSK9 particle is transcribed and translated via the nucleus, the ribosomes, modified in the Golgi apparatus, and then exported from the cell. Similarly, the LDL receptor is synthesized and also exported to the cell membrane surface. At the cell surface, the LDL receptor and the PCSK9 particle work to receive an LDL particle, engulf it into the cell, deliver it to the lysosome, where the entire complex is degraded. If we can block PCSK9 function via a monoclonal antibody or by stopping its production completely using a small interfering RNA, we can still deliver LDL receptors to the cell surface, accept LDL particles, engulf them into the cell, degrade the LDL receptor within the lysosome, but we can recycle the LDL receptor, send it back to the cell surface, and in this manner, we have an increased number of LDL receptors and therefore can take in and degrade an increased number of LDL particles. And the effect of this RNA interference drug on the synthesis of PCSK9 and the concentration of serum LDL cholesterol in healthy volunteers was studied in a randomized single-blind placebo-controlled phase 1 trial, and this trial showed a 70% reduction in PCSK9 and a 40% reduction in LDL levels. Investigation of PCSK9 has been deemed so important that it's been investigated in this decade and is reviewed in a series titled New Lipid and Lipoprotein Targets for the Treatment of Cardiometabolic Diseases. Let's take some time to look at other cardiovascular complications that can be managed with certain therapies. One cardiovascular complication is heart failure, which is the term used to describe a weakened heart muscle which doesn't pump blood as it should and can lead to a number of other complications. Two therapies to manage heart failure can be ACE inhibitors, which is angiotensin converting enzyme inhibitors, and these relax the blood vessels and can be used for hypertension or high blood pressure. And another therapy to alleviate heart failure is a calcium channel blocker, and these therapies have been shown to decrease the incidence of heart failure from 50% to 20%. Another cardiovascular complication is sudden death caused by a myocardial infarction or heart attack, and these occur through a blockage of a coronary artery that supplies blood flow and oxygen to the heart muscle, and when this is stopped, it can create angina pectoris, which is another term for heart muscle pain, and coronary vasospasm, which is when the coronary artery constricts. And calcium channel blockers can reduce both of these things, and it also reduces the intracellular calcium overload, which is a key step in ischemia-induced cell death that is implicated in sudden death through myocardial infarction. Let's now take some time to look at how HDL, or high-density lipoprotein, functions within lipid metabolism. As we discussed earlier, HDL is considered to be the quote-unquote good cholesterol and can be thought of as the highly desirable lipoprotein. HDL functions to reduce the oxidation of LDL lipids and therefore reduces the inflammatory cascade, and also reduces the collection of atherosclerotic plaques within the lumen of vessels, and therefore reduces the incidence of plaque rupture. Let's take a look at this process of how lipids may become modified. So reactive oxygen species are consistently produced within our bodies, and they can modify DNA, proteins, and lipids. These modified factors may fix to the endothelium or the luminal layer of vessels and stimulate the inflammatory cytokines interleukin-1, interleukin-6, and TNF-alpha. This stimulates the acute phase response, which creates the production of more reactive oxygen species and thus propagates the inflammatory state. HDL may function at every level of this process to break the cycle by working to receive LDL oxidized lipids, and can be understood to be the trash truck that sort of cleans up plaque buildup. Macrophages are a phagocytic type of white blood cell, and they make an effort to absorb the oxidized lipids fixed to the endothelium, and they store them as cholesterol esters. And here we can see that HDL will migrate to these macrophages and pick up the cholesterol and reverse cholesterol transport, which is why HDL is considered to be beneficial. HDL has a multifaceted role within the body. It's not just associated with the inflammatory response or lipid metabolism and transport, but also has many factors that have to do with hemostasis, the immune response, metal binding, vitamin transport, proteolysis and inhibition, and complement. HDL, or high-density lipoprotein, is not just composed of cholesterol, but rather has a broad range of lipid species that can be isolated from it, and some of them are listed here. As HDL, or high-density lipoprotein, is composed of a various number of particles, it also can vary in the amount of each particle, and therefore is not one homogeneous particle, but varies in its composition, making it heterogeneous, and we can classify HDL by its density and size. This schematic looks at the HDL subclasses based on diameters of the particles. Here we can see samples from 4 different patients, and this distribution varies on diameter and subclass. This schematic is an immunoblot that has plasma separated on the basis of charge and size, and we are looking at an HDL sample from 2 different patients, and we can see that the HDL particles are separated based on size and charge. And one important thing to look at would be this pre-beta particle, which is considered an empty shuttle ready to accept lipids. The ProCam, or Prospective Cardiovascular Munster Study, looks at the incidence of coronary heart disease, or CHD, with HDL cholesterol levels. And you can see here that as you increase your HDL cholesterol levels, there is a decrease in the incidence of CHD. This graph looks at HDL cholesterol levels and total cholesterol levels in association with survival probability. And you can see that both are important because as you increase HDL cholesterol levels, you increase survival probability. And as you decrease total cholesterol levels, you also increase survival probability. So this orange line at the top here shows low total cholesterol and high HDL cholesterol to be the best combination. This graph describes the relationship of total cholesterol in patients with non-coronary heart disease to patients with coronary heart disease, and you can see that patients have a broad range of cholesterol levels, and the population is described on this bell curve, which shows the average distribution of cholesterol levels. And the coronary heart disease patients, their average distribution is shifted to the right to show that they have a higher total cholesterol level average distribution. This graph looks at a number of different studies shown here: the Framingham Heart Study, the Coronary Primary Prevention Trial, the Multiple Risk Factor Intervention Trial, and the Lipid Research Clinic's Follow-Up Study, and again looks at plasma HDL cholesterol levels in association with coronary heart disease events per 1,000 per year. And again, it's re-emphasized that as you increase your plasma HDL cholesterol levels, you decrease the incidence of coronary heart disease events. So in conclusion, increased HDL cholesterol levels are good, but you still want to keep your total cholesterol levels. Let's look at the production of mature HDL within our bodies. ApoA1 particles can be produced by the enterocytes of the intestine or the hepatocytes of the liver, and ApoA1 can become lipidated with phospholipids and free cholesterol particles, which produces nascent HDL. And this nascent HDL can further pick up lipids from triglyceride-rich lipoproteins or peripheral tissue cells via the action of certain enzymes, such as lecithin cholesterol acyltransferase, lipoprotein lipase, and phospholipid transfer protein, which can produce mature HDL. Let's look at the degradation of HDL, and this occurs via the liver or the kidney, and lipase enzymes can degrade HDL back into ApoA1, which can then be filtered through the glomerulus and taken up by renal tubular cells and excreted. And the ApoE component of HDL may also bind hepatocytes and be degraded by the liver. HDL functionality thus depends on the interaction between the lipidome, or the lipid composition, the proteome, or the protein composition, and the particle's structure and metabolism. Regarding therapies, in addition to ongoing trials with anacetrapib and evacetrapib, investigations are still underway with other novel agents that can further probe the effect of raising HDL levels using the following, such as HDL infusions, HDL mimetics, newer CETP inhibitors, liver X receptor agonists, farnesoid X receptor agonists, RVX208, novel PPAR alpha, gamma, and lactam agonists, and microRNA inhibitors. Torcetrapib is a therapy that was developed in the early 2000s, and its development was halted in 2006 due to mortality in the treatment group that was receiving both torcetrapib and atorvastatin. And there was a 60% increase in mortality noticed, and after the study was halted, it was determined that this combination of the two therapies raised systolic blood pressure in the treatment group. And therefore, it's concluded that the side effects of certain drugs may outweigh the intended benefits. We've discussed a lot about lipid metabolism and the cellular processes of how these work. However, we shouldn't forget that our bodies are very complex and are composed of 100 trillion cells, 21,000 genes, 100,000 microRNAs, and 1,000 trillion microbes with their own 10 million. Beyond that, we have 500 chemicals in our circulation, 60% from us, 30% from other species, and 10% from biota. And our bodies are complex and operate with these various systems, and one way to also study their interactions is through looking at the human gene co-expression network. In conclusion, our main points discussed were geared towards keeping our LDL levels low and our HDL levels high. However, we don't want to forget to maintain a smart lifestyle. And what does that mean? You want to eat healthily and make sure you exercise, keep your stress levels low, stay happy, and to supplement with a proven therapy as needed. And that is going to conclude our presentation. Thanks so much for listening.